Good afternoon, and welcome to our panel discussion on sexual health. I'm Apurva Mandavili. I'm a reporter at the New York Times, where I cover health, mostly infectious diseases, and I'll be moderating today's session. Joining me today in the studio are Jay Varma, Nesli Basgoz, and Antón Castellanos Usigli, and Demetre Daskalakis is joining us remotely from Washington, D.C. Thank you all for being here today. We are seeing a resurgence of just about every sexually transmitted infection: syphilis, chlamydia, gonorrhea, and some of these were things that were essentially on their way out, maybe even close to being eradicated in this country. So why are they back? I want each of you to pick the factor that you think is the single biggest contributor and tell us very briefly why you think it matters.
Great, thank you, Apurva. When I started my career at CDC, one of the first diseases I worked on was tuberculosis, and I learned the cynical but sad reality that programs get eliminated before diseases do. And I think that's really what we're seeing as it relates to sexual health and sexual transmitted infections in the United States. It requires constant vigilance. Obviously, as your population grows, as people's interactions change and evolve over time, you can't expect these infections to go away without robust, culturally sensitive, affordable, accessible sexual health services. And so I think until we invest in the public health and the healthcare delivery side of this, we're going to continue to fall behind.
Nesli?
Thank you. I think broadly the reasons are related to an inadequate or reduced both societal and public health response to sexually transmitted infections and sexual health in general. And when I say societal, the broad factors include income inequality and poverty, social determinants of health, stigma, the epidemics we see periodically, that included HIV obviously, but also COVID, the epidemic of opioid use. And so in those settings, unfortunately, there's been a dismantling or a lack of adequate building of resources related to sexual health. And we're seeing the outcome of that now.
Yeah. I'll mention a couple of things on my end. So we don't have comprehensive sexuality education for young people at schools, and ignorance is rampant out there. I've heard people who don't know what HPV is or who don't know that they can get STI through oral sex, so that's one thing. Second, we're far from having sexual health embedded within primary care and preventive care. A lot of healthcare professionals fear the topic. They don't know how to address it with patients, so that's a big problem. Also, I'll say that over the last 10 years, we've invested a lot of funding, a lot of energy into the prevention efforts for HIV among men who have sex with men, primarily through PrEP. And so PrEP has been the focus of attention for the last 10 years, and we've neglected STI prevention and condom usage promotion. And lastly, I'll say that public health works well with governments, with nonprofits, with academia, but there are some businesses that have a large stake in this issue, and we're not working with them. Just to name a few: dating apps, pharmacies, social media, intimate wellness brands, and so they're part of the issue, and they should also be part of the solution.
Demetre? Oh, you're muted.
Are you able to hear me?
We can hear you now.
Oh, good, making sure. So I'll start by saying yes, and so I think that all of the above statements are right. I think especially the fact that really diseases respond to funding as much as they respond to antimicrobials. And so I think that you can see what happens when you accelerate with additional resources, work across many different sort of disease states, including STIs. I'm going to add to that there's also a couple of things that I think are important drivers. And I think we heard a little bit about sort of the acceleration of some of the work that's happening in HIV prevention. So I think that there's an innovation gap. So there, I think, is really exciting sort of movement that's happened historically in HIV as a viral sexually transmitted infection. And that same innovation has not happened as quickly in STIs. We have diagnostic tests in some cases that are decades, if not a century old, for some of the pathogens. And we have strategies that are sort of biomedical interventions for HIV that we don't necessarily have fully realized once launched for STI. So that innovation gap is a real one that is then made worse by all of the things that my other co-panelists have brought up. Thanks.
Okay. Well, very typically of public health researchers, these are all nested answers, answers within answers, and we'll have to explore them at length in this panel. But I want to take a step back and ask about something very basic, which is, Antón, something you referred to in your answer. Do we even talk about sex enough in this country? And you mentioned sex education and doctors talking to patients, but can you talk a little bit more about that? And then Nesli, I'd like to hear from you on that as well.
Yeah, no, we don't. And when it comes to public health, we're very good at developing services, programs, and communications from a risk-based approach. So we talk about the negative consequences of sex and how to prevent them, among them STIs, and that's it. That's where the messaging ends. And so why don't we take a broader approach of talking about sexual well-being, wellness, pleasure? Safer sex is pleasurable sex. But we've been really bad at marketing that message in decades throughout the years. And so it's 2023, and it's still difficult to see condoms in commercials or in advertisements. Think about it. Recently, AIDS Healthcare Foundation put a new billboard in Los Angeles featuring a banana covered by a condom with the slogan, "Just use it." And they couldn't place it anywhere else because several marketing advertising agencies rejected it. So this is happening in 2023, and look it up. There's an article out there that says condoms go bananas in Los Angeles. So happening in 2023. And so, until when are we going to be able to talk about sexual wellness in a holistic way and not be afraid of this?
Yes, I want to add to that. We often say that primary care doctors or other physicians aren't talking enough about sexual health and they're not doing enough to prevent infections. But I want to step back and say that many of these issues have become medicalized in our society. They can include things such as substance use, they can include things such as housing, and they certainly include sexual health. And all of you have heard about how many primary care doctors are leaving primary care. And that's because if you did everything expected of a primary care doctor, you would work 18 to 20 hours a day in an average primary care practice. So we can't abdicate sexual health education around sex to medical doctors alone. This is a societal responsibility, the way those other things are societal responsibilities. And yes, we have to talk about sex. We have to embed it in schools from a very young age. These are all evidence-based interventions. They work. And we need to make sure that regardless of what politicians think, the same people who think government should be out of your life should agree they should be out of your bedroom. And that is not something that is an acceptable approach, which is to stigmatize sex and make it unacceptable to discuss it in schools, in churches, and in society.
Thank you. Demetre, you brought up HIV, and we know that with HIV, race, and sexual orientation, and zip code, where people live, actually define the risk populations. And both, HIV and STIs, it seems like, may affect predominantly people of color. So can you talk a little bit about the patterns that we see with STIs? Is it similar to HIV, and also how do HIV and these STIs play together?
Great question, Apurva. So I think really the map that you see of sort of HIV incidence and prevalence really overlaps pretty well with what you see with the STIs. So I think you'll see sort of geographic predominance. So for instance, like I think trends in the South for HIV, for instance, are very similar for the other STIs, including syphilis, gonorrhea. Chlamydia is hard to say because chlamydia is very prevalent. But those other two, we definitely see some very clear overlap and also overlap in the populations. We think that at least about 10% of HIV infections are directly attributable to an incident STI. So that's an important sort of idea. So when we think about sort of what that costs society and what that costs individuals, really these STIs and sort of controlling these STIs end up not only being about sexual health and STI control, but also HIV prevention. So the interaction is pretty significant biologically, and also from the social perspective, which I think you brought up. These infections really do focus on communities of color, communities that have really significantly reduced access to services. They very often sort of follow the sort of stigma lines that we see so frequently in sexual health, as well as other sort of areas of personal health. So I think that the sort of story that we're seeing is really very similar, where there is clearly social synergy, geographic synergy, but then also clearly biological synergy.
And Jay, you worked with Demetre in New York City, where I would imagine a lot of these factors are really at play. So what are some lessons that you've learned from dealing with HIV and STIs in the city?
Yeah, I mean, I think, Demetre made the point, and it was one of the things that we really focused on, was using, STI services as the entry point for the entire range of sexual health and wellness. The most sort of concerning and devastating STI, of course, is HIV, and so that is the entry point for it. And it's entry point for things like even picking up, new onset HIV infection, which is the period in which people are most infectious. So it's really critical to look at that, when a person comes in with a bacterial STI, to consider the whole range of medical interventions they may need. And that also includes things like vaccination. So that's number one. Number two is understanding that these are social network phenomena, right? There's nothing biological about why it should be concentrated in the South or among people of color, or even among MSM for that matter. There are a small number of factors, but the bigger ones have to do with, just like the cold is transmitted or certain foodborne infections are transmitted by who you interact with, these are transmitted that way. So if you don't break that cycle and you continue to have inequalities and stigma as have built up over hundreds of years, you're never going to make a dent. So one of the things that Demetre and I worked on when we were in New York City is really identifying where are the groups at highest risk, engaging the community groups in those, and designing educational initiatives, outreach initiatives that are very community driven based on these different social networks. So understanding it as really a social network phenomenon is really critical. And our social media companies know how to do that. Politicians know how to do that. We need to do that in public health too.
Now, I want to talk about how we talk about these things in the public arena for a second. And going from your point, when we were talking about Mpox, when it came through, there was a lot of confusion, some misgivings, some dilemmas, even on the part of media companies. And when I was writing about it, about how much to emphasize that of these sexual networks and that it was a disease predominantly in MSM. I mean, men who have sex with men. Do we say that? Do we not? Is that stigmatizing, or is that actually just stating the facts? That was a very sort of complicated calculus. And so, Antón, can you talk about that a little bit?
Well, there's nothing stigmatizing about speaking the facts. And if we don't state the facts, then people are not going to know them, and then they cannot take measures to protect themselves. And that's one of the most painful things that we saw with Mpox, that governments around the world were not saying clearly this is happening between men due to sexual transmission. I looked at a variety of educational resources developed by governments in Latin America. Very few of them mentioned that. And so how do you expect people to take measures, again, to protect themselves, harm reduction measures, if you're not stating the facts? And so I also remember I was present in meetings with public health colleagues, healthcare providers who were not saying things as they were. And it was very frustrating. So again, this speaks about sexual stigma that still exists in 2023. History repeats itself. We saw that with HIV and AIDS decades ago, and now we saw it 1 year ago with Mpox.
And Demetre, the CDC, for the very first time, I think, spoke very frankly about some of these issues. And I'm curious, did you have pushback? Where did that come from, that messaging? How did you craft it? And what's going to happen next time?
So thanks for that question. So first, I want to reflect with Antón, like such a challenging balance, and sort of seeing a lot of that sort of from both the CDC vantage point and then later in the White House vantage point really has been interesting. But I think that the sort of lesson from the HIV playbook is one that was used at CDC to generate the evolving sort of communications around Mpox. And so really a lot of what we learned in HIV is, well, I'll just say what I always say, which is that when someone said the word gay-related immunodeficiency, that then created 40 years of stigma. So like we were very specific to sort of not sort of generate communications that said, this is a gay disease. Instead, we did something that, so by the way, that's really easy to do. Like that is a very, that talking point, just like Mpox is a gay disease, that transmits a lot of information and also generates a lot of stigma. And so what we did instead was really create sort of guidance and information that was focused on sexual activity, used language that CDC had never used actually around sexual activity. So things like sex club, sex party, like all these words, very clear ways of describing anatomy that are more sort of on the routine way that people mention it rather than the way the public health or science does, was a part of that. And then we did the work of getting that information to the messengers and platforms that are trusted. So I think that we for instance like worked with all of the hookup apps, the dating apps, the social networking apps, as some like to call them. So the social networking apps to make sure that we got the word out, including doing some social media like Instagram lives with the dating apps to sort of be online. I'll say that that it was remarkably easy to move the messaging through CDC. And so like I think we were all sort of prepared to have a long conversation, a lot of debate, but once the actual core beginning of the messaging was developed, it actually moved through clearance like within 2 days. So I think that because folks really understood the history and the sort of lessons from HIV, it was a lot easier to move it forward. And I can only imagine like what a different world we would have been in if in 1981 those materials were able to move quickly and that they actually came from public health.
So that's something that actually worked very well, I think, during Mpox. But as a reporter, I also saw some things that maybe didn't work so well. And one of the ones that really came up is how the communication between public health and medicine. It seemed like public health agencies would come up with policies that, Nesli, you were talking about physicians' lives that maybe didn't take into account how medicine is actually practiced in this country. So can you talk about what needs to change in physicians' lives and also in the way that public health and medicine work together?
I certainly can, and I will make a comment about what Demetre said, which is that I was the physician who diagnosed the first patient with Mpox in the US at our hospital. And it was not a simple calculation for me what to say and what not to say, because I lived through the era unimaginable to most of you, where people lost their work, their insurance, their friends, their family, ultimately their health and their lives because of HIV/AIDS. And so ensuring we don't stigmatize patients and ensuring we communicate in ways that don't do that is a really important part of what we did. And I do think the CDC did it very well. So how do we do that? Well, we look at priority populations and we ask, how can we communicate with them? And in the case of our patient, he actually said through apps that he could make contact with many of the people with whom he had sexual contact. And we said, please do that and tell us what you find out. And he had found out both from them and as they queried their clinics and their governments, a great deal of information that was useful to us. And we can do that in a societal way, as has already been mentioned, and meet people in schools, meet people in clubs, which is also being done, meet people anywhere those priority populations go. And as healthcare providers, we can talk about it in a way that's hospitable, that's destigmatizing, and that's a big part of what we do, but we can't provide all the services ourselves.
Jay, what do you think? How should medicine and public health sort of deal with this topic together?
Yeah, I mean, I think, if we think about just from a healthcare delivery to medicine perspective, which is where your question is, I really think it actually starts also in training. I can't tell you the number of physicians that just simply don't know how to ask questions about sex without feeling ashamed themselves or imposing their own stigma on it. And I do think this MPOX discussion relates to that. People didn't want to talk about anal sex or sex parties or anything else because they themselves had their own sort of internal sort of sex negativity. And so I do think that the entire sort of medical and healthcare establishment, just like it's going through a lot of soul searching about how to be equitable and how to ensure diversity and cultural sensitivity, needs to be doing the exact same thing with sexual health. One of the things that Demetre and I worked on when we were at New York City Health Department was trying to identify and almost brand which are these sort of LGBT friendly, like which is a place that really destigmatizes sex and anti-stigmatizes, it makes it sex positive from the moment you enter and go all the way through. And I think that's really where it comes down to. And I think when that happens, public health and healthcare delivery will play well together.
I mean, it also seems really complicated to figure out not just where you target the messages, but when you talk about them, which groups to emphasize. And I think about this with something like syphilis, where we seem to see a lot of conversation about congenital syphilis, which of course anything that affects babies immediately horrible and totally preventable. But is that the right focus? I mean, when we talk about syphilis, should the attention be so much on congenital syphilis versus other people?
Is that for me? Yeah.
Yes.
I'll start. And so I approach this question kind of from two frames, and I'll try to keep it brief. One is, of course, we as a society value mothers and babies, as a future generation. And congenital syphilis is devastating and lifelong, as opposed to, say, a syphilis infection in an adult, which more often can be picked up either if you miss it the first time around, the second time, and still be cured and recover. So it's a devastating lifelong infection that I think we should focus on. I spent 20 years practicing in public health around the world and have worked with a lot of elected officials. And I have to say, quite frankly, one of the ways you bring resources to public health, which is unfortunate, but one of the ways you have to do it is you have to amplify the problems of those whose society broadly seems to value more than others. That's not the world I want to live in. I want everybody's lives to be considered equal, but I also know that when you focus attention on mothers and babies, the antenna prick up of every elected official across the world. And so I do think there's a medical reason to focus on congenital syphilis, but there's also a way to bring attention to this devastating issue of syphilis by focusing on those who nobody stigmatizes in any way and everybody feels an urge to protect.
Demetre, I don't want to put you on the spot here, but from a government perspective, if, one of the problems is the lack of sex education and young women, for example, not being aware of the effects from having chlamydia or syphilis, are there any plans, are there any programs that could begin to address some of that, or are there plans to institute some of those programs?
So I think there's lots of answers there. So I think that ongoing sort of on the federal level, there's a lot of work to make sure that schools specifically have the information that they need and the educational materials that they need. The challenge is that it's not a federal decision. And so I think that the continued work sort of on the state level to make sure that sort of what the more global US vision is in terms of this information being disseminated is also included sort of on the state side. I think going back to the innovation gap, I think that there's also a lot of work happening around diagnostics that may potentially ease access sort of within environments where we're actually testing not just for one pathogen, but for multiple pathogens, including syphilis, which I think could be a game changer, especially sort of in the lives of people who are coming for routine care. And syphilis may not be on people's differential diagnosis. They may go, oh, this looks maybe like a herpes lesion. And so instead of having to have the provider think about it, what if the test that you were doing actually tested for syphilis as well? I think that the other very important innovation that I think is one to watch with data that really is, and this innovation equals program. So that's a really important piece. Like as the science rolls out, there's sort of potential for actually programming that supports the effort is doxypep. And so I think that this is post-exposure prophylaxis using doxycycline. There are a couple different data streams around this. One, studies that happened outside of the US focusing on women did not appear to show effectiveness of the intervention. I predict, though I'm not sort of on the study teams, that this is probably not a biological issue, but more of an issue of adherence and other sort of parts of that. There's also studies in gay, bisexual, other men who have sex with men, and transgender folks that support the use of this. And so this is a space to watch with, I think, expected to see guidance from the CDC around this coming out sort of later in the year. With that said, I think that the ship has sailed with a lot of providers already thinking about this intervention, because that innovation gap of there's a chemoprophylactic that you can give for HIV that can prevent acquisition doesn't have its corollary with STI. So if there's the potential for giving chemoprophylaxis like an antibiotic to prevent acquisition of gonorrhea, chlamydia, and syphilis, that's potentially a game changer, understanding that there's never a free lunch and there are other downsides that folks that need to be considered in the calculus. So I think and then also avidly looking sort of at some of the vaccine products that we see for meningitis B that potentially may have activity against gonorrhea. Again, that is, the science there is lagging a bit behind in terms of being accelerated into guidance, but that's also an important spot to watch. So the most likely innovation to launch sooner is going to be DoxyPEP, which, like I said, many providers that serve the gay, bisexual, other men who have sex male population, they're already on top of it, with some cities already coming out with guidance and really launching this effort. Thanks.
Okay. Well, Demetre just covered a lot of ground as a government representative there. But we have academics here, and we have, Jay, you just joined a pharma company, so we have all these different perspectives, and I'd love it if the rest of you could also take a minute to say how you think all the different parts of society can come together to work on this.
Yeah. Well, I think Demetre's leadership has been fantastic, and leadership matters. And so if you have a leader who knows the community, who knows these issues, understands it, then the response is going to be different. And the example that he talked about liaising with businesses like hookup apps or dating apps, so important that we think about those stakeholders that we're not bringing to the table. That's an example of a great initiative, but we need more. And we need the involvement of the mainstream dating apps as well that have feared for many years to engage in this conversation, in part because of a stigma. I believe that there's also some very strong preconceived ideas about women's sexuality that they have that have prevented them from, engaging thoughtfully with these topics and providing useful information and resources to their users. So I think it's time that we think, how can we drive innovation through these partnerships with businesses and dating apps. They're just one example, but there's other businesses that are impacting people's sexual lives. Pharmacies, you mentioned social media as well. So I think that's a very important point. And I'll just add, to what Demetre was saying, in light of all of these innovation with biomedical interventions, I think also what Mpox brought upon last year was a revitalization of condoms, of the conversation about the role that they play for risk reduction. And so that was something very important that I saw after many years. The conversation had been forgotten among gay and bisexual men. But I also heard, for instance, a colleague from the UK who was distributing condoms in bathhouses at the height of the Mpox outbreak. He was giving out loops condoms, and some people were not very welcoming to the idea of receiving condoms. They said to him, this is just a turnoff. So again, we have to work with messaging across all of these interventions, the biomedical and condoms, making sure that we don't stigmatize any of them and that we present them as valid options for people to consider and for them to make their own choices. But we have failed with the messaging over and over.
Couple things. One is I think we tend to focus on behavioral risk and sometimes de-emphasize societal risk. And remember, 30% of young adults in the US don't have health care coverage. Mm-hmm. And in Massachusetts, we're privileged because in many cases we can access health care coverage. But that is as strong a risk for a sexually transmitted infection as the behavioral risks we're talking about. The second is we have to ask ourselves, what drives innovation? And when we say innovation, we also often mean drugs or devices, but diagnostics are part of that. behavioral innovation is part of that, educational innovation. And historically, it's been profit. And if you are a clinician, you know that when a drug is coming off patent, that's suddenly when it becomes safe for over-the-counter use. Prior to that, it's always deemed unsafe unless it's prescribed by a physician and sold to hospitals or physicians. So I think I completely agree with Demetre and others about innovation, but we also have to look at what drives innovation. And society and public health have to step in where otherwise it would purely be profit motives driving those innovations. And I feel very strongly about that. I'm sure Demetre does also.
Mm-hmm. Okay. Great. No, I mean, I think, in the dream scenario, of course, is that we have a revolution sort of led through government where sex is seen as what it really should be. It's good for your physical health, it's good for your mental health, it brings pleasure, it brings connection, it's a net good to individuals in society. I'm pessimistic about that, given the politics of that have existed in the United States for a long time, and so do you think leaning into this concept of innovation is going to be critical? It comes from pharmaceutical companies like the one I work with that works on a drug used and evaluated for monkeypox, but it also occurs in all these other areas that I think Demetre and Nesli and Antón have talked about, and I would love to see this sort of broader revolution of sexual health as wellness, kind of the way fitness became in the sort of 70s and 80s, where it's destigmatized through the commercial market, and that could integrate diagnostics and vaccines and therapeutics in a way that is self-affirming as opposed to seeing stigmatized right now.
Well, thank you all for those great answers and for this very lively discussion. It was a pleasure to moderate this discussion. For our audience, if you missed any part of this program or you want to re-watch it, a recording will be available on the YouTube page and website. And please join us for our next event, When Antibiotics Fail, Solving the Deadly Superbug Threat, on September 26th at 1 p.m. I'm Apurva Mandavili. Have a great afternoon.